Where does this leave crizotinib, a drug that still has activity that can be long-lasting for many patients, tends to be less active, though, than any or all of these second-generation ALK inhibitors, and with less activity, but not none in the brain. So does your view change that you would be inclined to move these second-generation inhibitors up front if they're paid for, or would you still favor giving crizotinib until progression and then getting whatever you can get from a second-gen inhibitor, Leora?
So we have trials that are going to answer that question, and it's similar to with the EGFR frontline trials, where I think the combined survival when you're on crizotinib and then you get a second-generation inhibitor should be combined compared to getting that second-generation inhibitor up front. And so that I heard that this meeting that the ALK trial is closed. The 396 phase 3 trial is going to be opening. And so we have studies that are going to answer these questions for us.
But it would have to be, when we're looking at progression-free survival, a statistically significant difference of 4 months may be enough to declare a winner as first-line therapy, but that's not the same thing as showing it's the better strategy compared with sequential first-line crizotinib followed by second-line, second-generation ALK.
Correct. Or can we see that, 50% of patients on the second-generation inhibitor do not get brain mets?
Right.
That'll be something that'll be meaningful.
Different view?
Yeah, no. So look, I think crizotinib is a great treatment, and I think there's we still have patients who are on the original phase 1 trial of crizotinib, continuing on crizotinib.
You'll retire before they're
Yeah, that's right. I hope. I think that is the current bar, and I think the standard first-line treatment for patients with ALK rearranged lung cancer at present is crizotinib, and I think
which is also often very well tolerated by patients too.
Yeah, and I do think the ALK trial will be an important trial because alectinib is another really well tolerated drug which does have better brain penetration, and I think that result will be an important result. But again, I think we need to see how the data pans out, and I think we need to show that these drugs are better than crizotinib before moving them into first line.
How would you approach a patient who is on Xalkori, crizotinib in the first line setting and develops 2 small brain metastases that you can treat pretty readily with stereotactic radiosurgery, gamma knife, cyber knife, and continue them on Xalkori if they have no progression outside of the brain? Or are you inclined to change them to a second-generation ALK inhibitor with the thought that it has better penetration in the brain? Ben, why don't I start with you? Yeah,
so in that particular instance, I think if their disease outside the brain was still really well controlled and they were tolerating the crizotinib well, and my radiation oncology colleagues thought that those 2 lesions were suitable for stereotactic radiosurgery, I would go ahead with the stereotactic radiosurgery and continue the crizotinib. I think it would be a different situation either if they had disease that was starting to progress outside the brain, or if they had multiple brain metastases that needed whole brain radiotherapy. And in that context, when we know that there are agents that can work in patients progressing on crizotinib or that might work better in the brain and therefore delay the time that for them to need to have whole brain radiotherapy, that's probably my trigger to switch.
Your thoughts?
I agree. I do the same.
Very good.